All right, thank you very much. Senator Monning, did you have some comments?
I was on page 17, the chart that reflects total cost of the different IT projects. Can you give us any sense of what's the timetable? Where are we in the development of these projects? These multi-year projects, do they have different target dates to be completed?
Yes, these projects span, they are in different developmental stages. Some of them are in the planning stage, others are at the implementation and development stage, and so it varies. In general, I would characterize it as within the next 5 to 6 years, implementation will be achieved. For example, the CWS new system project is in the planning stages of the effort, and in all likelihood, it's about a $350, $400 million effort, won't be fully implemented until the 18-19 fiscal year.
And so when we look at these total cost allocations, that's for the completion of the project, and that total cost spans multiple budget years?
That is correct. Yes.
And are we getting periodic reports of how that's being drawn down and percent of project completed?
Generally, the projects come forward each year if they have a need through the budget process. So you are seeing regular updates relative to these efforts. Our concern within agency is we want to make sure that we're maximizing federal dollars for the projects. We want to build them in the way that multiple departments can leverage the systems that are being put in place. Every department feels strongly that their particular systems need to address their issues, and we want to make sure there's a more comprehensive agency-wide strategic approach being taken.
Thank you.
So I think Senator Monning probably shares the same thing I'm about to say. When legislators hear about IT proposals, we stop. Unfortunately, we've learned some very difficult lessons over the years with the development of IT programs and projects in the state. So I appreciate your thoughtful review. I do want to ask a few questions with regard to, I know we're discussing right now the ability for departments to share with departments, discuss with departments, perhaps have some shared contracts with departments to drive down costs, maybe share expertise. It's a very complex situation we can't talk about in just a few minutes here, but I appreciate that you're interested in sharing across departments. This might not be a fair question to ask, but in the executive branch world, do we also have that discussion agency to agency to make sure we're using our dollars to their best extent, their best efficiency to develop these programs for all of our important state data needs?
Yes, Madam Chair. The technology department has the overarching statewide responsibilities to ensure compatibility between systems and within agencies, between agencies. There would not be a duplication here because we really need experts relative to the health and human services arena. The federal Medicaid standards, the MIDA standards, at the state level, our technology department does a good job in understanding kind of the broader picture, but we need to be able to do the deep dive analytical work within health and human services. So yes, we do have the overarching IT governance structure in place. This proposal, however, would do more of the deep dive within a health and human services agency.
Right, I understand that. We've heard some presentations recently that our procurement systems sometimes block our ability to really find the very best of vendors and maybe cut our costs when we go out to bid or procure these contracts. Do you have any thoughts or concerns about our current procurement process and its ability to allow you to find the very best solution for the needs?
Madam Chair, my apologies. I'm not an expert in the procurement world. I know that the state has faced challenges in the past. I think the technology department may be more suited to answer that overarching question. I can tell you that within the Office of Systems Integration, that we do have a core team that's specifically dedicated to ensuring we have good, strong contracts in place so that in the event that projects don't go the way intended, we have the contractual language to enforce any penalties that are necessary and ultimately solutions that meet the needs of our people. And so I don't know, I'm not an expert in the procurement world, and I really can't answer that question.
Yeah, and I just raised that question because I think that's something we should be asking as we move forward on these projects that are very, very important, and they are, once we make the decision to go down the road, sometimes we cannot turn back. So we need to really make sure that we're getting our best bang for our buck and the very best programs. So I just raised that. Maybe it's something that can be discussed further as we take a look at this.
Madam Chair, I fully agree. I would expect that our agency information office would also be exploring what are the various procurement models that are successful,
yes,
and having a dialogue with our technology department and other control agencies relative to what is the best model to ensure success.
Yeah, it's a very important discussion to have,
Agreed.
I think. Thank you very much. Any public comments on this item? Please come forward.
Beth Capel for Health Access California. One of the things that the implementation of health reform has taught us is how important the IT systems are to getting this right. Currently, there are significant problems in the Medi-Cal program as a result of the interface between the newly developed CalHERS IT system and the Medi-Cal IT system. So and it is impeding the enrollment of some categories of people into Medi-Cal. Conversely, looking forward, we've had considerable success with scanning the CalFresh enrollment and have found 550,000 adults who are Medi-Cal eligible and shamefully 150,000 children who were Medi-Cal eligible and who are being given the opportunity to enroll in Medi-Cal. Those children should have been enrolled all along. Some of those adults are newly eligible. So we have these IT system issues, which I have hoped to avoid during my entire career, are nonetheless really important to assuring that people get enrolled in the programs that they should and that we maximize the capacity of the existing health and human services programs and the interactions between them in order to maximize enrollment in the programs people are eligible for. Thank you.
Thank you very much. I really couldn't agree with you more. These systems are so important to everything that we do, and I know you know that, so thank you for the presentation. Any other comments? All right, this item we will be leaving open, so we will be discussing this further with you. Thank you very much for your presentation. All right, the next item is transfer of the Medical Privacy Breach Program to the Department of Public Health. Please come forward. Welcome to the presenters. Good morning.
Good morning. My name is Scott Vivona. I'm the Acting Assistant Deputy Director for the Sniffer Healthcare Quality from the Department of Public Health. I'm here today to present the next proposal on behalf of the agency as well as the Department of Public Health.
Thank you.
This proposal seeks to request position authority for 3 positions and a funding authority for $251,000 for the LNC Special Fund with a commensurate reduction in the Health and Human Services Agency authority to consolidate within the Department of Public Health the enforcement of medical privacy statutes. The goal of the proposal is to streamline and improve the protection of patients' medical information by combining the enforcement investigation from the Department of Public Health and the California Office of Health Information and Integrity breach information enforcement statutes. In 2008, statutes were enacted to provide the authority for the Department of Public Health to investigate proposed or alleged breaches in health facilities and created the Office of Health Health Information Integrity and the Health and Human Services Agency. The Cal OHI investigate investigations against individuals, while the Department of Public Health investigate investigations against facilities. This proposal seeks to transfer the positions from, 3 positions from the agency to the Department of Public Health Licensing Certification Division to consolidate those functions. The staff from Cal OHI will attend our training academies in the Department of Public Health. Staff from both departments will be cross-trained so that we can do simultaneous investigations to reduce and improve efficiencies for the investigation and more timely investigations of those investigations.
Thank you very much. Department of Finance, LEO, any comments, questions on this? All right, thank you very much. Senator Mani, do you have any thoughts? Public comments on this item? All right, thank you very much for the presentation. We look forward to the adoption of this program. I know you will treat it with all sensitivity, and thank you for that. And this is an item that we will be holding open. Thank you very much. Next item is overview of the Department of Public Health. Good morning.
Good morning.
Yes, it is.
Still is morning.
Yes, it is.
Thank you, Madam Chair, Committee. My name is Dr. Ron Chapman. I'm the State Health Officer and Director of the California Department of Public Health. Appreciate your inviting me to present. Senate Bill 162 reestablished the California Department of Public Health in 2007. Our department employs approximately 3,500 people in over 60 locations around the state and administers a proposed budget of $3 billion. Our mission is to optimize the health and well-being of the people of California. Within the proposed budget, $638 million, or 23%, is for state operations, and $2.3 billion, or 77%, is in local assistance. This is an 11% decrease compared to the fiscal year 13-14 Budget Act. The vast majority of this reduction is due to the proposed transfer of the drinking water program and the environmental lab accreditation program to the State Water Resources Control Board, and a proposed reduction in WIC local assistance due to lower food costs resulting from USDA's directive to lower reimbursement rates for small stores. The department works to keep us all safe and healthy through the delivery of quality public health services. We rely on public, private, and community-based partners at the local, state, national, and even international levels to help us accomplish our mission. We achieve our mission through the following core activities. We monitor health status to identify and solve community health problems such as our safe drinking water, food, drug, and medical devices safety programs, and infectious disease monitoring. We track vital statistics such as mortality and a variety of chronic diseases. We work with partners to address health problems and health hazards in the community, such as our work to prevent infant deaths and premature births, which are now at historic lows. However, it's important to note there are huge disparities that exist in those populations, and support for the highest risk moms continues to decline. We inform, educate, and empower people about health issues such as our breastfeeding education and tobacco education campaigns, and we promote public health policies that support individual and community health efforts, such as the successful partnership in 2011 with local public health departments, education, the healthcare system, and the legislature to control the largest pertussis outbreak in 50 years. We enforce the laws and regulations that protect and ensure safety, such as the licensing and certification of healthcare facilities, and we link people to needed personal health services and assure the provision of healthcare when otherwise unavailable, such as AIDS and HIV care. And we prepare for public health emergencies such as wildfires, drought, and earthquakes, and large-scale infectious disease outbreaks with all of our local partners, including hospitals, schools, businesses, and local public health departments. And we strive to maximize our existing resources. We need to be an effective and efficient organization in order to deliver high-quality public health services. And to achieve this goal, I and the department's executive team have taken a systems approach. We have completely revised our internal contracting process and are considered a model in state government. We have led the way in zero-based budgeting, which improved the business operations in several large programs, including WIC, our Women, Infants, Children's program. We have a strategic plan which has a cross-cutting strategic objectives such as make continuous quality improvement a way of life in the department, achieve health equity through public health programs, and expand and strengthen collaborations and partnerships. I began this job with a vision of achieving national public health accreditation, which involves systems improvements to meet 105 nationally accepted measures. And after an 18-month process just last month, we submitted documentation of our efforts to be reviewed by a team from the Public Health Accreditation Board. The benefits of the accreditation process have been many, including a modernized workforce development plan, the creation of the department's first ever quality performance plan, and a quality improvement infrastructure, including QI teams and a quality performance council. Public health is all about preventing disease and keeping people healthy and safe. Thanks to the Let's Get Healthy California work, we have a vision of California being the healthiest state in the nation by 2022. And to achieve this vision, we need to reverse the trend of increasing obesity in adults and children. Unfortunately, physical activities remain low, and the consumption of unhealthy foods and sugar-sweetened beverages continues to be high. Neighborhoods and communities should be designed to promote physical activity, and we need to increase access to healthy foods and beverages. Nearly 40% of Californians live with at least one chronic disease. Almost 60%, or $51 billion of California's healthcare expenditures, were for people with multiple chronic diseases which are largely preventable. Health inequities exist across all chronic diseases, and we are striving to include a health lens in policymaking through our Health in All Policies work. Our chronic disease work includes the prevention and control of a number of chronic diseases, and the work focuses on the underlying risk factors, such as tobacco use, physical inactivity, and poor nutrition. And these risk factors are largely influences by the communities in which people live and the social determinants of health, such as education level, employment status, and poverty. Infectious diseases such as tuberculosis, valley fever, hepatitis C, and sexually transmitted diseases continue to threaten the health of Californians. And our infectious disease work relies heavily on public health laboratory testing on our department's Richmond campus and in county public health departments across the state. These labs play a unique role in testing and surveillance which hospital labs and private labs do not perform. And the backbone of public health in California is the partnership between local public health departments and the California Department of Public Health. Public health is only as strong as that partnership. Much of our surveillance, outbreak investigations, emergency preparedness, and program implementation are accomplished in collaboration with the 58 county health departments and 3 city local health departments. When I walk down the street, I see public health in action everywhere I look. Streets designed to encourage walking and biking and reduce pedestrian injuries, children wearing helmets while biking, babies and infants safely buckled in car seats, and children who have been vaccinated against infectious diseases which 100 years ago would have taken their lives. And I do not see people smoking in restaurants. We've accomplished much, but the work of public health never ends. In 2009, public health responded to the H1N1 flu pandemic, and in this flu season, H1N1 continues to dominate and cause deaths. And we are fortunately armed with a vaccine to prevent these deaths. E-cigarette use is growing exponentially and threatens to undermine California's tobacco successes, which have saved over 1 million lives in the past 2 decades. The future success of public health in California is dependent upon a strong partnership with local public health, healthcare systems, and community-based organizations, a robust public health workforce, and support from local, state, and federal governments. I want to just conclude by thanking the thousands of California public health workers who have dedicated their careers to protecting and improving the health of people in this great state. Thank you.
Thank you, Dr. Chapman. Thank you for the very positive report.
Thank you.
And the good work that's being done by you and all of the people who work with you.
Thank you.
Thank you. Do we have any questions on this item, Senator Monning, anything? Oh, yes, I'm going to ask them in just a second. Department of Finance or LEO? All right. Yes, Senator Monning.
Thank you, Dr. Chapman, and for your leadership and visionary leadership of the department. I had a couple of questions, just kind of updates. You alluded to the response on the pertussis outbreak, or I don't know if it was classified as epidemic, but kind of update on that, and then also recent reports on measles. If you could just give us status reports on both those areas.
Sure. So with pertussis, we, again, worked as a team, came together, created new laws in California for children to be vaccinated and booster vaccinations. The impact of that was substantial. We went 2 years, in fact, in a row without a single death from pertussis in California, which was absolutely unprecedented. Unfortunately, we're now seeing an uptick in the number of cases of pertussis, and we've had our first death since the last few years. And, you know, part of that is our ongoing challenge with some very focused areas in this state that have lower childhood vaccination rates. So education is really important. Working with physicians, providers is very important. And we're tracking that increase very closely.
Can you, offhand, do you know the particular geographic areas that have proven to be at greater risk?
You know, I don't know those off the top of my head. Again, we are tracking that. The individual county health departments are keeping track, and we do have reports that talk about individual vaccination rates by schools, and that's available.
And then on the measles front, there's been some news about that recently.
Sure. So as well, we're seeing a very unfortunate increase in measles cases, and part of this is from travel to foreign countries that have very low measles vaccination rates. These children return, they develop cases of the measles, and then that puts other children and families at risk. You know, there's this whole concept in public health about herd immunity, which basically means that we have to have a high enough percentage of people in our communities to be vaccinated in order to protect the entire community. And measles is one unfortunate example where we're seeing increased cases.
And the increase is the result of somebody returning who's been exposed, but then people who have not been immunized
Correct.
Being at risk.
Correct.
Thank you. And then on the work on obesity epidemic, and that is considered appropriately epidemic. Is that correct?
Correct.
Does your budget include any resources for public service announcements to promote public education? I think one of our battles is there's so much focused advertising of unhealthful foods and products, and often not a countervailing media presented public information. Does your budget allocate anything towards public service announcements on better nutritional choices, importance of exercise, et cetera?
You know, we have a statewide obesity prevention plan. We recently released our California Wellness Plan, which is our state's chronic disease prevention plan, and there are obesity components in there. From what I know, mostly what we have are educational campaigns about healthy eating and physical activity. They're not necessarily anti-obesity campaigns like what you're speaking of.
But what you are speaking of, is there an aspect of that that uses electronic media, television, radio?
I'm actually not sure. I'll need to get back.
Yeah, I would think one of our challenges is that we're not on a level playing field, and all of the efforts of public education seem to be in the province of local health departments, nonprofit groups, often working on very tight budgets, as your department does as well,
Right.
And just can't keep pace with the onslaught of targeted and focused advertising that often targets children. And I would think it would be worth exploring with media in the state of California, if the department, in collaboration maybe with nonprofits committed to public health, could produce effective public service announcements to enlist the support of the media to run those as public service announcements. So a little beyond maybe the budget we're looking at today, but I'm just curious if there is any component in the budget to foster those efforts, because I think if we don't compete on that level, we're going to see the epidemic and the trends get worse, not better.
So we'll need to get back to you on that particular information. I do want to make you aware that we just released information on a project called Healthy Stores in Healthy Communities. And we, in collaboration with local health departments, we had 700 people gathering data from around the state from over 7,000 stores to actually study the types of advertising that you're referring to. And that data was just released yesterday. There's been a lot of press coverage, so important information.
Thank you very much. Thank
Thanks.
you, Madam Chair.
Thank you.
Would you be willing to speak a little bit more about your concerns? You touched on it. I haven't heard it touched on in a presentation like this before. Your concerns about the use of e-cigarettes.
Sure. As a department, we're monitoring this very closely. I've been in several meetings with the director of the Center for Disease Control, CDC, Dr. Tom Frieden, where he has expressed publicly concern about the growing use of e-cigarettes. And so we're seeing a trend across the country as states look at whether or not to treat e-cigarettes like a tobacco product. We are, as a nation, waiting for the Food and Drug Administration, the FDA, to put out some kind of guidance on this. We're still waiting. And then across the state, we're watching a number of local ordinances actually be passed, taking a stand, basically stating that e-cigarettes should be treated as tobacco. I believe LA, Los Angeles City Council just voted to do that in the last few days. Thank you.
Thank you very much for your presentation.
Thank you.
Did we have any public comments on this item? Please come forward.
Good afternoon. Kathleen Hamilton with the Children's Partnership. I'm also here on behalf of the California Children's Health Coalition, which includes the Children's Partnership, Children's Defense Fund California, United Ways of California, PICO California. Did I say the Children's Defense Fund? As the committee considers this overview of the department, we appreciate this opportunity to note and hope that you will at some point also take up some programs within the department which have been eliminated in recent years during some of the more challenging fiscal times in California. A handful of very important and very effective programs serving children's health care needs were eliminated, and we hope there'll be an opportunity to talk about restoring them. Just want to point out that they include the Early Mental Health Initiative Program, the Black Infant Health Program, and the Children's Dental Disease Prevention Program. So I'm not sure if you'll be taking those up in detail at a later date, but we wanted to note that part of the department overview ought to include a review of those programs which have been eliminated, and we have hopefully an opportunity in this more stable budget environment to think about restoring these very effective and important programs. Thank you.
Thank you very much.
Madam Chair and members, Bruce Palmer with the Health Officers Association of California. I'd like to support what Kathy Hamilton said and reiterate that over the last several years, 69% of the local assistance dollars have been cut, much of which also goes to the county level. The group I represent represents health officers and local health departments administering communicable disease programs, protecting food, providing safe water. The action occurs at the local level. These are fundamental services that are as fundamental as police and public safety at the local level. They're basic services of a civilized society. And after years of cuts at the state level, and years of cuts because of a declining economy at the local level, it's time to consider some reinvestment in these basic services. Dr. Chapman very eloquently talks about California being in 10 years the healthiest state in the nation. But if we don't start reinvesting in some of those fundamental basic public health protection services, we're never going to reach that goal. I spoke about it some of the policy decisions that were made last year we have to take a very close look at to see how they impact the local level. Realignment funding also included not just patient care funding, but it also included public health funding. And so when some of that money is directed back to the state, it puts pressure on public health budgets at the local level. And when you cap growth, that doesn't give us a chance to recover in terms of building our programs back up again. So we hope that we work as partners with the state. We have some very good relationships with the State Department of Public Health, but we're going to have to start looking at a way of funding these critical disease prevention programs so there's equal protection throughout the state and it doesn't depend on how wealthy your county is or what necessarily they can provide in one location. It has to be a statewide approach. Thank you.
Thank you. Hello.
Good afternoon. My name is Susan Forster, and I've just retired from the California Department of Public Health. I wanted to respond to Senator Manning's question about media work. And it is true that there is no state funding at all for media work in the area of nutrition and physical activity and obesity prevention. However, we do put in about $10 million a year out of our federal money from the Network for Healthy California that you're going to hear about in a little bit. But we've had several campaigns. One was called What's Harder? Another one is called Ownership, which focuses on particularly childhood obesity. And the research that we've been able to do suggests that where we combine the paid media with the boots on the ground programs, we are seeing changes in reported behavior. I don't think we're seeing any obesity changes yet, but the paid media in markets that reach the underserved population during day parts and programming and in billboards and so forth does seem to make a really big difference. So, but it is totally dependent on federal funds.
Thank you. Could I just ask a question on that? I appreciate that added information. It's helpful. You said paid. Is there any way to get the information onto electronic media without having to pay for it? Do you know?
We did start with public service announcements in the past, and they simply are not adequate in reaching the population. It's not something that stations are doing very much anymore, and we're responsible for $110 million getting results for that. So we need to place the media at times and in locations and in ways that actually reach the population in a sustained, predictable way.
And I assume that's done in multilingual, multicultural?
It is always English and Spanish, yes. We do not have any other languages except print in Asian languages right now.
Thank you.
You're welcome.